Hello, good evening, and welcome to your health program. I'm Marie Yambo. Today we focus on one of the biggest threats that we face as a human race, antimicrobial resistance. That simply means resistance to antibiotics. Antimicrobial resistance, AMR, is the biggest public health problem facing humanity, with an estimated 10 million deaths by 2050, according to the World Health Organization. In 2019 alone, 27 deaths per 100,000 was recorded in sub-Saharan Africa, more than HIV and malaria combined. We will be learning more about a new technology known as bacteriophages, what they are and how they work. But first, let's talk about antimicrobial resistance, and I'm joined by Dr. Lilian Musila, a biomedical research scientist with decades of international research, academic and teaching experience in microbiology, and currently works at the Kenya Medical Research Institute, KEMRI. Welcome to the program, Dr. Musila.
Thank you so much, Marie.
Nice to have you here.
Yes, it's a pleasure for me to be here again to address this topic that you said is one of the largest public health threats that is facing us.
Exactly. Now let's start by first of all painting the picture. How serious is the problem of antimicrobial resistance in Kenya?
Yeah, Marie, this is a problem that is very huge globally. The figures that you mentioned are true. We anticipate that there'll be 10 million deaths by 2050. And the problem with these figures is that the burden of that problem is going to end up in low and middle income countries, and particularly in sub-Saharan Africa, where we sit. So we have these global numbers, but in Kenya there are scientists who've been tracking antimicrobial resistance. And one of the things I'd like to say is that since antibiotics were discovered in 1920 with penicillin, Alexander Fleming warned that when we discover a new antibiotic, it will be very shortly followed by resistance. Because bacteria, once they're exposed to an antibiotic, can very quickly develop resistance. So following on the development of penicillin, other classes of antibiotics were developed. But true to his word, as soon as we develop a new class, then we get resistance to it. So we currently have quite an arsenal of antibiotics to be used. But if we look at the picture in Kenya, one of the drugs that is most popular are the penicillin drugs. And we find that many of them are almost useless because they have resistance rates of up to 80%. Now, another class of drugs, it's a beta-lactam drug in the same kind of family as penicillin, but a bit more advanced, are the cephalosporins. And I think we might know them as ceftriaxone. And a study showed that this is the second most prescribed class of antibiotics in our hospitals. And let me tell you that we have resistance rates almost close to 50% for this class of drugs. And it also mirrors how much it's used within our hospitals. We have another class of drugs called fluoroquinolones, and these are used a lot for treating diarrheal infections and also urinary tract infections. And for these infections, it's such an important class of drugs for these types of infection, but we're seeing rates of up to 40% resistance. In the study that I run in KEMRI, we look at these classes of drugs, but when these fail, we move to another class of drugs, for example, carbapenems. And we see here about a 15% rate of resistance, and for some of the organisms, almost up to 60%. So you can see how quickly we're running through our classes of drugs. Now, when we stop using carbapenems, what is the next thing that we use? We use last-line drugs like colistin. And for colistin, even though the rates are low, over the years we've been seeing it growing, up to rates like 14% in some organisms. So let me shock you. We test for resistance against some of the pathogens that the World Health Organization has said is the priority pathogen for new antibiotics because we are running out of those. And when we track those 6 bacteria that fall under those priority pathogens, we find about 54% of them are multi-drug resistant. What does that mean? It means they're resistant to 3 or more of these antibiotic classes. Yeah. And more recently, we've been finding some pathogens for which every single test that we run says resistant, resistant, resistant. And this is the kind of report that we send back to the doctors. I received a call from a doctor one time and he told me, Dr. what kind of a report is this that you've sent me? I have no options. And the fact of the matter is that even here in Kenya, we're running out of options, especially for bloodstream infections, some surgical site infections, for people who have to stay in hospital for long, this is becoming more common than we would like to imagine.
Mm-hmm. We will be coming to talk about especially the people who are more at risk when it comes to antimicrobial resistance. But probably just to make it simple, because misuse of drugs. I mean, recently we've even seen it on making headlines, over-the-counter medication. I'm wondering how, let me say, who is to blame in this situation? Because there are those who go to the doctor, it is prescribed, you go to the pharmacy, you buy it, and then obviously there's the over-the-counter, medication that people can just go and buy. So at what point would you say someone is misusing antibiotics? Because if I have a child, especially that's the age group that I think sometimes we use a lot of antibiotics on, there's a cough here, there's a flu over here. Just to make it simple for the person out there listening, at what point would you say now you're actually misusing the antibiotics?
Yeah, Marie, you've pointed at two main reasons why we're in this crisis. One is misuse, and misuse just basically means that you're using antibiotics when you shouldn't, or you're overusing it. So let's talk about misuse. So misuse, a study showed that less than 1% of antibiotics that are prescribed based on a test that has shown that this is what you need to do to treat. So what are the other 99% doing? It's just informed guesses by the physicians. Okay, so another study showed that 54% of people are prescribed antibiotics when there's no need to. So let me go back to the children. Your child has a cough. Of course, we are very concerned about our children. So we take them to the doctor and we said, my child is coughing, can you give them an antibiotic? Now, coughing or sore throat can be caused by a viral infection. That doesn't need antibiotics. It can be caused by allergies. That doesn't need an antibiotic. But we don't actually test if they have a bacterial infection. So especially in young children, there's a lot of overuse of antibiotics for infections that are not caused by bacteria. So that's one of the reasons for misuse. As I told you, in a hospital, 54% of people given antibiotics did not need to be given it. And this is especially for pneumonia, for post-surgery, for wound infections. They don't always need antibiotics, but they're often prescribed. So misuse is part of the reason why antibiotics are increasing rapidly. The other, so overuse, but there's also misuse. This is when you use the wrong antibiotic for the infection. We had a sad case of a young boy who had missed school for a couple of months because he had a wound that was not healing, and it was growing larger and larger to the extent that he couldn't go to school. Now, when we did an actual test to see which antibiotics can kill this infection, we found that it was a different class of drugs, but not expensive, readily available. And when we switched him to the right antibiotic, his wound healed in 2 weeks, and he went back to school. So that's what happens when we also misuse it. We don't actually know what we're doing. So this boy had been exposed to antibiotics for 3 months, but really needed maybe just a 2-week course of the right antibiotic. So the key with antibiotics is to get it right, to hit it hard, to use it for the right dose, the right duration, and the one that will kill the bacteria. And that's the proper use of antibiotics. Okay.
And very important there, I mean, what you've just explained, if anybody is listening or watching, I think the minute you are treating an infection and you're using antibiotics and it's not responding, that in itself is telling you you need to actually seek medical advice and not self-medicate.
Yes.
You know, I know at the beginning of the program you had mentioned a few of the kind of infections that you're actually handling right now that are resistant, but I will just take you back again just to make it simple for the viewer to understand which are these infections that you're seeing that are actually becoming hard to treat.
Yeah, so one of the most difficult to treat are bloodstream infections. So that's when a bacterial infection enters your blood and it goes through your whole body. Those are really difficult to treat, and they're often associated with being in the hospital. So you either have an IV or you have a catheter, some kind of device that has penetrated your system so that it gets into your system. So a lot of very drug-resistant bacteria associated with blood infections. But you also get infected wounds, either from surgeries or just from other types of wounds. You also have pneumonia, some of the biggest causes of infections. But you also have the common ones, the UTIs, the urinary tract infections, the throat infections. So it's a whole range of infections that the bacteria can infect.
Okay. And you know, you've talked about throat infection, and I mean, you see a lot of that with children. And I know of a case where a child developed rheumatic fever, and from my understanding is that the misuse of antibiotics can lead actually to rheumatic fever, which can actually be very deadly eventually if it's not caught in time.
Yes, the overuse of antibiotics can trigger other types of infections. So it can, like you're saying, rheumatic fever is one that can be triggered. Can also trigger diarrheal infections caused by a bacteria called C. difficile. So one of the things that antibiotics does is antibiotics not only kill what is causing your illness, but it also disrupts your natural bacteria in your system, what we call good bacteria. So we need good bacteria for optimal health, but when you use an antibiotic, especially for long, it kills all your good bacteria in your system, and your system loses imbalance, and you can get secondary infections by things that your good bacteria would normally keep away. So that's one of the bad side effects of using antibiotics and using them for long.
Mm-hmm. And then the other thing is, you know, we use antibiotics for the day-to-day treatment of, you know, like you said, respiratory infections and all that. But there are people who actually, their lives depend on these antibiotics. Yes. And if they develop resistance, it could actually mean it's a matter of life and death. And
yes.
Those are people who are going in for surgeries.
Yes.
People who have gone through, organ transplants. Yes. Probably you can touch on that, because it's very easy to say, oh, I had a flu, I took antibiotics. But you might just find yourself in a situation where you need surgery. Yes. Of any kind, or people who are undergoing chemotherapy, those who have cancer, they are actually facing a very difficult moment. Yes. The minute that you have developed bacterial resistance over time.
Yes, yeah. And that's a very good point. That in an individual who is otherwise very healthy, we all are exposed to bacteria in our day-to-day life, but we can ward it off because our immune systems are quite effective at fighting ordinary bacterial exposures. The problem when we use those antibiotics to treat infections that we could otherwise handle is that the person who really needs it, the one who's in ICU, the one who has undergone chemotherapy, as you mentioned, those amongst us who are immunocompromised, those people with cystic fibrosis and other diseases that make them unable to fight bacteria effectively, are the ones who are most affected. Particularly those who depend on very long stays in hospitals, who again have a lot of gadgets and things put in their systems. They are the most vulnerable, and they are the ones who cause the most deaths. But in the study that you referenced, looking at attributable causes of death, well, they found that the children under 5 are very susceptible, especially to bloodstream infections. So we see a lot of mortality in that age group due to resistant infections.
Okay. And then, you know, the role of doctors, pharmacists. Have we reached a point where probably now we need to have prescription for antibiotics? Because at the rate that it is right now, definitely we've gone, you're talking about 50% of most of the antibiotics, we cannot treat ailments. Is it time that we have prescriptions for antibiotics?
Yes. When the World Health Organization declared this global threat, they had some policies that they implemented, and Kenya adopted a national policy to prevent and contain antimicrobial resistance in 2017. And one of the pillars that they had was regulating antimicrobial use. Now, one thing I haven't mentioned is that about 60% of antibiotics are not used for human medicine, but are used for animal medicine.
Exactly.
And if we say that the regulation is poor in humans, it's even worse in animals. And we use a lot of antibiotics for animals, not to treat infections, but to just keep them healthy and plump, and for them to grow faster. So that's not an indicated use for antimicrobials, and they're mixed in with the feeds. So very difficult to regulate. So one of the things that Kenya is doing is to establish policies for antimicrobial use within hospitals. So that's called antimicrobial stewardship. Why are you using third-line, fourth-line antibiotics when you could use lower ones? So to regulate how we use them, but also in the animal industry, what exactly is in our animal feeds? Are we regulating how much antibiotics come in the livestock industry? Because bacteria affect humans and animals the same way. We're all animals at the end of the day. So you can't deal with the human industry and forget the livestock industry. So the government is implementing policies to regulate antimicrobial use, but also many hospitals are now establishing committees to see how are doctors prescribing. And some studies have shown that when they begin to monitor how doctors are prescribing, they actually see a lower prescription rate for some of these higher level drugs, which means that we're preserving a lot of our classes so that we can have some options, so that those who really need it can actually get the antibiotics that they use. But if I can just talk about the flip side of that, the irony of a country like ours is that we have the very rich who can afford the third, fourth line drugs, but we also have those who die because they can't get even the basic drugs. So when you talk about regulation, we have to regulate in a way that those who need it get it, and those who are overusing or misusing it, it's regulated. So we have to find that really careful balance.
Okay. And then there's a new technology that scientists have been developing, because I understand it's been there for years. But yeah, we are going back because, like you said, Alexander Fleming talked about resistance, and probably people did not pay attention, and they're called bacteriophages. So this is the new frontier in as far as you know, antimicrobial resistance is concerned. But first of all, it's a very technical word, you know, bacteriophages. What does it exactly mean?
Yes, so bacteriophages has brought a lot of hope to our industry, where we usually pronounce bad news. Bacteriophages simply are viruses that affect bacteria. Bacteriophages literally means eaters of bacteria. So we're all familiar with viruses that affect us, like COVID. We're aware of viruses that affect animals and plants. So these are just viruses that affect bacteria. And anywhere in nature where you find bacteria, you find bacteriophages. So they're just naturally occurring wherever you find a bacteria. These viruses are very specific to bacteria. So they will target only a specific bacterial type. So let's say something like E. coli that maybe many of us have heard of. There's a bacteriophage that will attack only E. coli and only some strains of E. coli. So they're that specific. Now, before antibiotics were developed, some scientists had already discovered these phages in the course of their bacterial work. They would notice these patches when they grow bacteria. And they said, what is killing these bacteria? And they found that they were phages. And they had begun using them for therapy, and they had treated a lot of people with diarrheal infections successfully. But when antibiotics were developed, they kind of shelved that, and we used antibiotics. Until now, we are in the era of superbugs where antibiotics are not working. So we're saying, wait a minute, let's go back and explore what these phages used to do. So bacteriophages work in this way. They're viruses that will recognize that very specific bacteria that they can attack. They'll put their DNA inside the bacteria. The bacteria will start making these viruses, and they'll become so many that they'll burst the bacteria and they'll kill it. So we call them lysing the bacteria. Now, this bacteria has made very many more of these phages, so they'll go on and look for other bacteria to attack, and the cycle will continue until all the bacteria are cleared. So it's a very effective way of clearing of the very bacteria that is making you sick without interfering with all your good bacteria that we talked about that antibiotics destroy.
And exactly, as you've mentioned, you know, advantages of using bacteriophages vis-a-vis using antibiotics is that the bacteriophages are targeted at certain bacteria, unlike antibiotics, which will clean the whole system of the good bacteria, which we definitely need, I mean, for your digestion and for overall good health. And so, but is it not expensive to develop bacteriophages?
Yeah, the bacteriophage field is actually really new, and it was precipitated by how many people were developing these superbugs. And people said, look, I have a patient who's dying, I have no other options. There's this option, can I use these phages as kind of a last resort? So just in the last decade or so, bacteriophages have been being used for emergency use, where a doctor says, I have nothing else. Can I use this just to try? And the good news is that for many of these cases where they've used bacteriophages for this emergency use, those patients have recovered, they haven't seen any negative side effects, and so people have begun waking up to the possibility of developing this into like a proper field. Just a couple of years ago, they did the first clinical trial for bacteriophages in Europe, and just recently, big funders are putting in a lot of money into the development of bacteriophages as therapy. And private companies are also developing to begin to develop these bacteriophages.
Okay. Okay, continue.
But let me tell you what, the thing that makes it good is also the thing that makes it challenging. Because you see how specific it is. It means that we need to be hunting constantly for phages against bacteria that are bothering us. So these WHO priority pathogens, we have to be looking for phages in the natural environment, and these phages need to be put in a bank so that if you have an infection, for instance, of E. coli, then we already have a number of E. coli phages that we can use to test against your infection and treat you. So in the absence of a phage bank, then it's too difficult to hunt case by case for bacteriophages.
Where are we as Kenya in terms of the use of bacteriophages? Are we already using it in our health institutions? And where are we in terms of, like you talked about, the bacteriophages bank?
So globally, bacteriophages are not used broadly in health, other than in the former Soviet Union countries in Eastern Europe and in France and Belgium, where they routinely use it for therapies. For other countries, the challenge is people don't quite understand how to regulate their use. Is it a drug? Is it a natural therapy? Is it like, what do we do with it? So I think regulatory issues are still being dealt with. But here in Kenya, in the program that I run in KEMRI and other scientists as well, we've been hunting for phages within our environments here, within rivers and waters and sewage and so on. And we currently have approximately 400 phages against some of these priority pathogens that the WHO has said. The challenge is that these scientists who are doing this work, we're working in different pockets. So we have a group at ILRI working on phages against Salmonella for chicken. We have groups in KEMRI working on these pathogens, these bacteria that affect humans. We have some groups at the Institute of Primate Research, again working on health phages. We have others working on bacteria that target fish. So this year we held our first bacteriophage conference to bring all these scientists together and say, look, how can we put our resources together and actually make this a resource that we can then use for different applications. So the bacteriophage scientist community is small but growing. We're looking for funding to support this work. We want to develop this national phage bank so that there is a reservoir of phages that we can use, and then we're trying to create awareness to the public that phages are an option for treating multi-drug resistant bacteria.
So, Dr. Musila, even as we come to an end, I'm told my time is running out. In just a few seconds, can bacteriophages develop resistance?
Yes, they can. I'm glad you brought that up. The problem is bacteriophages will develop resistance against, bacteria will develop resistance against bacteriophages. But viruses are also very quick at adapting. So they adapt very quickly and switch to be able to also fight the bacteria. So now it's a race against bacteria and virus, which is a much equal race than bacteria against humans. So if they develop resistance, we just go look for a new phage that has also countered that resistance. So that's one of the really big advantages.
Okay. Thank you so much, Dr. Musila, for your time and coming into the studio and enlightening us in as far as antimicrobial resistance is, some of the solutions like bacteriophages, which are now being developed, to target the bacterial resistance. And so we would love to have you next time. I'm sure this is a topic that would have gone on and on.
For sure.
But we can always have you back in the studio, to talk about bacteriophages especially. So thank you also, our viewer, for joining us this evening. Thank you for your time, and be sure to join us again next time, that is next Saturday, for another edition of Your Health. I'm Marie Yambo. Do have a great evening.